Welcome! In this lecture, I will describe several bacterial organisms which cause lower respiratory infections and pneumonia. I'll start with tuberculosis, which is caused by Mycobacterium tuberculosis. Mycobacterium is arguably the #1 bacterial pathogen worldwide. Approximately half of the world's population lives in areas where TB is endemic. There are approximately 10 million cases of active TB with over 1 million deaths every year. And an alarming number, nearly 500,000 cases of TB are highly drug-resistant. Mycobacterium is a gram-positive rod with an unusual cell wall containing mycolic acid. This characteristic makes the organism positive in the acid-fast test. Its waxy cell wall protects the organism from phagocytosis, and it can survive for weeks on dry surfaces. TB is transmitted through the respiratory route. The inhaled bacteria are ingested by lung macrophages, which usually clear the organism in healthy individuals. But if the person is immunocompromised by poverty, malnutrition, HIV, or other factors, the organism can establish an intracellular infection. More and more macrophages are recruited to the infected tissues, and eventually calcified lesions known as tubercles form in the lung. These tubercles can grow and rupture, releasing mycobacterium deeper into the lung and on into the bloodstream. TB progresses slowly, and many patients are not aware they are infected until well into the disease process. Symptoms include a bloody cough, weight loss, and extreme malaise or exhaustion. Historically, starting in the Greek classical period, these symptoms together have been described as consumption. The cause wasn't known until Robert Koch discovered the etiologic agent in the 1880s. Untreated, the organism can spread to other organs, including bones, kidneys, spine, and meninges. The diagnosis of TB includes several tests. The PPD skin test is a screening test employed in the United States. In the test, a small fraction of bacterial protein, purified protein derivative, is injected under the skin. If within 48 hours the site becomes red and raised, it indicates a delayed hypersensitivity T helper cell response. A positive skin test indicates the person has been exposed to the TB organism only, but it does not necessarily mean the person has active TB. The skin test can also be positive if the person has received the TB vaccine or was exposed years ago and is well now. Follow-up tests include a chest X-ray to look for evidence of calcified tubercles in the lung. If the X-ray shows tubercles, this indicates the person has had active TB at some point in their lives. To determine if the person has current disease and is infectious to others, a sputum sample will be collected. Classically, an acid-fast or a fluorescent antibody stain will be done. Additionally, a sputum culture will be done on specialty media. If these tests are positive, the person has active TB and is extremely infectious to others. The patient should be put in respiratory isolation as soon as possible. Newer and more rapid tests using PCR, polymerase chain reaction, and DNA probes are being developed. Currently, they are too expensive for most clinical labs. The BCG is a preventative vaccine which is administered in many countries where TB is endemic. The United States does not use the vaccine because of its relatively low effectiveness, about 60%, and because it would invalidate the PPD screening test. Hopefully, a better vaccine will be available in the near future. Treatment for TB usually involves a cocktail of at least 3 drugs: INH, or isoniazid, rifampin, and pyrazinamide. These drugs have to be given for 6 to 12 months. Unfortunately, drug resistance is becoming a huge problem worldwide. Multiply drug-resistant strains such as MDR-TB are common. There are even some strains of TB which do not respond to any of the classical drugs. These are known as XDR-TB strains. To get an understanding of the gravity of this situation, check out this link. We need new drugs and a new vaccine for TB. The sooner, the better. Another important pathogen of the lower respiratory tract is Streptococcus pneumoniae. The organism is a gram-positive coccus, typically found in chains and in pairs. It produces an antiphagocytic capsule, which greatly increases its virulence. In culture, it's alpha hemolytic and sensitive to the antibiotic opticin. Recall that another important species of strep, Streptococcus pyogenes, is beta hemolytic and bacitracin sensitive by comparison. The symptoms of bacterial pneumonia include fever, chest pain, and a productive bloody cough. Don't ignore these types of symptoms. Streptococcal pneumonia has an extremely rapid onset and progression. Some cases advance to meningitis within a few hours. The demographic group with the highest incidence of this type of pneumonia, though, is the elderly. Also, those immunocompromised by HIV or treatment with steroids, radiation, or chemotherapy are at higher risk. Classically, pneumococcal pneumonia occurs as a complication of a viral cold or flu. The viral infection weakens the individual, and the increased mucus makes it harder to clear the bacteria which are already present in the nasopharynx. Often, these patients believe they will recover on their own and don't seek medical care. Sadly, untreated mortality for pneumococcal pneumonia is still around 25%. The good news is that there is now a conjugated vaccine which appears to be very effective. It should be administered to all babies, the elderly, as well as those immunocompromised by other conditions. Since the organism has become resistant to penicillin, fluoroquinolones are the standard treatment for streptococcal pneumonia. Another form of bacterial pneumonia is caused by a very unusual organism. Mycoplasma pneumoniae causes what's known as walking pneumonia or primary atypical pneumonia. What makes this organism unusual is that it is a bacterium without a cell wall. It's also extremely small, about 1/5 the size of E. coli. The organism is difficult to grow in culture, and its colonies are so small that a microscope is required to see them. The colonies themselves have a characteristic fried egg appearance, as seen here. The disease is relatively mild compared to streptococcal pneumonia. Patients have a low-grade fever, headache, and prolonged malaise. They have a non-productive cough, which is similar to the dry cough of a cold, only with mycoplasma the cough lasts for nearly a month. The disease is most common in children, adolescents, and young adults. Diagnosis is based on the fact that the organism is beta hemolytic on specialty guinea pig blood agar plates. Faster diagnosis can be made through PCR, polymerase chain reaction, or demonstration of acute current phase antibodies of the IgM class. For treatment, tetracycline family antibiotics are usually effective. Since the organism doesn't even have a cell wall, penicillins would be a waste of time. The final bacterial pneumonia I will discuss is Legionnaire's disease. This type of pneumonia is caused by Legionella pneumophilia. The name comes from a 1976 Legionnaires' convention in Philadelphia, where nearly 200 people came down with a mysterious and devastating illness, and 30 of them died. Eventually, the epidemic was traced to the air conditioning system of the historic hotel where the convention was being held. We now know that the causal organism is a gram-negative rod, which is ubiquitous in wet environments. The bacterium's natural habitat is in freshwater lakes, ponds, rivers, and streams. Outbreaks have been traced to humidifiers, hot tubs, showers, fountains, and any water source which splashes and can become aerosolized. Check out this link to learn of a relatively recent outbreak of Legionnaire's disease in Chicago. The disease risk factors are highest for those over 50 years of age, male, smokers, and those who have impaired lung function or immunocompromise. The symptoms are similar to other forms of pneumonia, except for the fact that the patient's fevers are extremely, almost ridiculously high. Patient's fever may reach over 105 degrees, which is quite rare in adults. Even with proper treatment, many survivors suffer permanent lung damage. It is thought that endotoxin release is responsible for many of the more serious symptoms of Legionnaire's disease. 25% of untreated patients will die from it. Fortunately, the organism responds to erythromycin if it's given early enough in the disease process. Pneumonia remains a common cause of death in the U.S. and around the world. It can be caused by a number of different bacteria, viruses, and fungal organisms. It's critical for clinicians to properly diagnose the causal agent of a pneumonia in order to give the correct treatment for the disease. In this lecture, I've described 4 bacterial organisms which can cause pneumonia: Streptococcus, Mycoplasma, Legionella, and Mycobacteria, or TB. Each of these 4 organisms requires a different antimicrobial drug treatment. Clinicians need to carefully consider the age of the patient, ability to produce a sputum, degree of fever, and gram stain before initiating treatment. Students will be asked to test their own diagnostic skills on the lecture exam. Be sure to read the clinical examples in the book and attempt the practice case histories as well. This concludes Diseases of the Respiratory System, Part 2.